Before I met my husband, I was always worried about, am I going to be able to get pregnant? When we were dating and I would see couples with kids, whether it's the woman, the man, how does the person who's not dealing with the infertility, how do they support their partner? Ready? 3, 2, 1. Dr. Stephanie Thompson, welcome to the group chat.
Dr. Stephanie Thompson is a board-certified reproductive endocrinologist and infertility specialist with expertise in obstetrics and gynecology.
We never go into life thinking that we're not going to be able to have a child, but unfortunately, it's not the case. That's why we do have egg freezing to help.
When do you realize that we're going to need to take the IVF route?
We did it 2 years ago. There was a lot of frustration because you realize people just do this. And it was the easiest thing in the world.
Right. We can talk about the celebs and all that too.
For a while, we saw from Mariah Carey to J-Lo to Angelina Jolie, all of these celebrities having twins, and you started noticing it wasn't a coincidence.
Dr. Stephanie Thompson, welcome to the group chat.
Thank you. Happy to be here.
Happy to have you. We've been talking about the topic of fertility and IVF. Mona and I, for actually many years, I went through IVF, and I know she's having discussions with her husband about expanding her family. And so we figured it would be a great time to bring you on because all of us have so many questions.
That's true. I'm here to educate.
So tell me a little bit about your background because you talk about this publicly too, quite a bit.
Yes, I do. So I'm a reproductive endocrinology and infertility specialist, which is a fellowship after obstetrics and gynecology. So it's a long road to get here, but it's great. It's great. So I've been in private practice for over 10 years and just help women through their journey of trying to have a baby. And I also help women in their family planning when it comes to things like egg freezing.
Yeah. And it's been, this has been available for decades. I would imagine so much has changed since you first got into it. What would you say has been the biggest shift that you've seen?
I think the biggest change is how successful we are, honestly. Like even in the time from I started fellowship to practicing, our success rates are really amazing when it comes to IVF. And I think that's really important for people to know. Of course, it's never a guarantee, which is, one of the misconceptions out there. But, it is quite successful. It can take a little time, but definitely, we get there. And I also think the egg freezing technology has dramatically improved as well, too. 15 years ago, it was considered experimental. Now we're at the point where you can really use it for your family building and planning.
So as Jeannette mentioned, I'm 33. And my husband and I are starting to talk about expanding our family and having kids. And there's so many options when it comes to, do you freeze your eggs first? Do you do IVF?
Yeah.
So before we get into all of that, I want to know, what is IVF exactly?
Right. So I'll just start off by telling you guys what infertility is, right? Because I think that definition is often sort of misconstrued as well, too. So infertility is when a woman is trying to get pregnant and can't get pregnant after 12 months of unprotected intercourse, if you're under the age of 35. If you're over the age of 35, that number goes down to 6 months of trying to conceive. And personally, but this is not an official definition, I think if you're over 40, really, if you've been trying for 3 to 4 months, then you should see a fertility specialist if you're having difficulty getting pregnant.
Is it to lower the threshold so you can act sooner since time is
Exactly. Unfortunately, age is one thing that we just can't turn back. Our biology has not caught up to where we are in society. So if you are older, the sooner you take action, the better your outcomes are actually going to be.
I do want to talk to you about that, the number you threw out, 35.
Yes.
Because I've heard that was based on an outdated study and that it's rooted in sexism and it's a way to force women to have children earlier.
I would love to believe that it's wrong, but it's not. It really isn't, unfortunately. Just like I said, our biology has not caught up to, where we are living. That age is where we start to see a decline in our egg count. So there's two things that, we will see when we talk about age 35, quote unquote. There's advanced maternal age, which is where we start to see greater complications with a pregnancy and an increase in chromosomal abnormalities. And I'll use Down syndrome as an example because it's the most common one. That increases after 35. But what also increases decreases after 35 is your egg count and your ability to become pregnant. And that decline, it really does start at 35. You know, we're not just using that as a scare tactic, but scientifically, when you look at pregnancy rates from 35 to 37, you start to see a decline, and that gets very dramatic 37 onwards. And if I had a little graph to show you, I would, you know, but essentially 35 to 37 is somewhat of a slope like this, and then it goes straight down. So unfortunately, that's real. It's reflected in pregnancy rates, it's reflected in miscarriage rates, and it's reflected in chromosomal abnormalities that we see.
Just for some perspective, what's like the ideal age, biologically speaking, right?
Oh, 18.
Huh.
I mean, seriously.
Get your driver's license and have a baby.
Right. So, you know, it's never like a 50% chance that you get pregnant when you try and conceive, right? The greatest that it is somewhere around 35% when you are, you know, around 18, 19. Those rates go to, when you hit age 30, you know, approximately 17 to 20%. And that's per cycle that you attempt to become pregnant, per menstrual cycle.
Yeah.
Right? And at 35, it goes to 15%, at 45%, and at 45, less than 1%.
It's so crazy because you spend so much of your teens and 20s avoiding pregnancy.
Exactly.
And it's like, if he kisses me.
Right.
Get pregnant.
Exactly.
And then you realize just how difficult. I mean, there's a very specific window, and then not to mention carrying through the entire pregnancy.
And it's supposed to be natural, right?
Yeah.
Like, we never go into life thinking that we're not going to be able to have a child. That is the most natural thing that, you know, a woman should be able to do. But unfortunately, it's not the case. And we, you know, have great technology now to help women as well, too. And, you know, that's not saying go out and, you know, everybody just try and conceive when you obviously you can't do that, you know, to have a child when you have to do it when you're ready.
Yeah.
But that's why we do have egg freezing to help as well, too. You know, and I think that we just have to be aware. We have to rewrite women's health care. And I think we have to rewrite like how we're teaching young women about their bodies and about their future reproduction and things that can help them to protect their bodies and what they'd like in the future.
Yeah, because I almost feel like the rug is pulled out from under me. Like, I spent my 20s working on my career and not being ready for children.
And that's great.
Yeah.
You know, that's a good thing. You know, we should be doing that. We have so much more opportunity now as women, but we have to balance that with our desire for a family. And is it fair or is it right? It's not. But, you know, there's nothing that we can do to change that when it comes to age.
But you can act and plan accordingly.
That's right.
With the right information. You were going to.
Yep.
Yeah. I was going to say, with that, like, is the ideal age to freeze your eggs then when you're in college, for example?
No, I think that's young. Quite honestly, I think the ideal age is probably somewhere around 30, in the sense that you get great outcomes from your eggs, right? Your eggs are nice and healthy and young. And also, I think that's when most women are maybe emotionally and financially ready too. Of course, we freeze eggs, you know, at all ages, right? For different situations. You know, we do have some teenagers who may have a cancer diagnosis, and it's appropriate. So all of this is a one-on-one conversation with you and your physician, no matter what. But optimally, you know, I think in your early 30s, maybe even late 20s is a time when your outcomes will be the best.
Is it? I thought you were going to say, by the way, earlier, like in your, if you can financially, in your 20s, because your eggs are younger. But I guess on the flip side, you don't want to. You don't want to freeze them as long?
Well, one, you don't. Actually, the length of time that an egg is frozen doesn't matter at all. So they can technically be frozen indefinitely. We flash freeze them in liquid nitrogen. So that part doesn't matter. But yes, there are storage costs, you know, that you have to think about too. I think it's also not totally, it's a medical procedure. So there are risks. There's risks like ovarian hyperstimulation, which the younger you are, the higher your risk for that will be. The decline in egg quality in your 20s is not as great. So I think you can wait a little bit. I don't think you have to be 20 or 22 to do it at all. I think it may even be riskier from the perspective of getting something like ovarian hyperstimulation, which is where you make so many eggs that your ovaries can become overloaded. But there are scenarios where it does make sense to freeze, you know, when you are in your mid-20s. For some women, they do have excellent coverage, from an insurance perspective. And your doctor will just be careful with you, right? We're not trying to get you to make 50 eggs. If it happens, it is, but that's not what our intention is. And there are women with a family history of premature menopause, a family history of endometriosis or endometriosis themselves, ovarian cyst, other diagnoses that may make it reasonable to do that. So, all of it, it's not blanket. You just have to talk to your doc. And then same thing on the flip side, right? Like what's the max age? Realistically, the outcomes from eggs over the age of 43 are poor, right? There are situations and scenarios where it does make sense for women to have that conversation and to consider it. But the outcomes are just not going to be as great. And that's the same with IVF. And I do want to circle back to your question about what is IVF, right? Because that helps us to also understand what egg freezing is. So
what is it and what is it not?
Right. What is it? What is not is a guarantee. It is a medical procedure. IVF is in vitro fertilization. It's an assisted reproductive technology. And it's essentially where we take eggs from a woman, which we have to surgically remove, and sperm from a man and put them together in the laboratory. That's the in vitro part. In vivo means that it happens, on its own. So with IVF, we have women take injectable hormones, and what you're taking is injectable gonadotropin. So those are the hormones that your brain makes naturally to tell your ovaries to grow an egg. Well, normally you make 1 egg a month, with IVF, and the meds we're giving you, we're trying to get you to make, 5, 10, 15.
Oh my gosh, tell me about it.
Right, exactly. Yes, we're trying to get you to make a bunch. And it takes about a week and a half of those injections with ultrasound and blood work monitoring to grow the eggs. Then we do put you to sleep and remove the eggs vaginally. And then we have them in the laboratory. And like I said, we fertilize them with the sperm. Now, for egg freezing, we don't fertilize. So egg freezing is just the eggs.
So the procedure is the same?
The procedure is exactly the same as IVF without fertilizing. So for IVF, we take the sperm, we fertilize the egg, we create an embryo. And then we grow the embryo in the laboratory, generally for up to a week. And then we have the opportunity to either do further screening on the embryo, or we can put the embryo directly into your uterus at that time to try and get you pregnant.
It's so funny as you're walking through all of this, because we did it 2 years ago. And every step there's, at least for me and for my husband, just a lot of anxiety. Because you want to be able to make it to the next step. Did you grow enough eggs? Did they get fertilized? Did it make it to day 5? And while there was a lot of, I guess, frustration because you realize people just do this.
That's right.
You know what I mean? Like my sister had 6 kids and it was the easiest thing in the world.
Right.
And we had to go through this entire process that wasn't as personal as I would have liked.
Yeah, it feels unfair.
Yeah, it feels unfair. But then on the flip side, you just kind of marvel at the technology and the medical advancements. The science. Like I can't even imagine, like we got to see Bella as an embryo.
Right? Exactly. You put that in your baby.
Oh my goodness. Yeah, right.
Yeah, it's really, it's incredible. I mean, that's what drew me to the field was the science. And I mean, our embryologists are the true genius, I have to tell you. They're the ones who actually work with the eggs and the sperm and the embryos in the laboratory. And they've created culture medias that are basically physiologic to your body to create an environment for these embryos that they grow and develop just as well as they do in you. And that's one of the advances. I mean, years ago, we didn't have these amazing culture medias. We couldn't get the embryos to the same stage where they implant in you naturally, but now we can. And hey, it's probably even better in some ways too. But realistically, like that's been one of the advances. We have culture to what's called a blastocyst that you mentioned, and that is the stage you would normally implant in you. Years ago, okay, remember when you guys used to see like people having twins and triplets and whatnot from IVF?
Yeah,
we don't do all that anymore.
Ask you about that
because we don't do that anymore.
That it's not like happening by accident. Let's just say that doctors were implanting more than one. I guess because it increases the chances that one will make it. But was there also on the patient side saying, hey, like I want to possibly have multiple?
Now that's what you'll see, right? Okay, and we can talk about the celebs and all that too. But in the past, we did transfer multiple embryos. And I'm talking probably a solid 10 years in past where that was. more of our norm. Single embryo transfer is something in the past decade to 15 years that we're doing. So we put back 2 embryos, one because the culture stage or the stage of growth and development of the embryo was earlier than it would have been naturally. So we would watch them till day 3, and that's when we would implant them. So we'd put back more than 1 embryo so that we would have a better chance of pregnancy. Most still resulted in singletons, but there was a significant amount of twins and sometimes even triplets. And how many embryos we would put back then really had a lot to do with how they appeared in the laboratory and the patient's age. Now, I would say in my practice, probably 90% and above single embryo transfer because we've gotten to be able to develop the embryos, you get into a better physiologic stage. We also are doing a lot of chromosome screening on them where we make sure all the DNA is present in the embryo, and that gives us much higher success rates. And we found that in putting back multiple embryos that are as high quality as the ones we do now, it just gives you a more significant risk for twins, but not a significant increase in pregnancy rates, in a way that it would make sense. And we don't want you to have twins, okay? We do not want you to have multiples. It's very cute, but the reality is that twins from IVF and twins from fertility treatment do have a poor outcome in terms of prematurity. That's one of the bigger issues. There's also things like gestational diabetes and preeclampsia. And as we get older and in minority women, those risks are real, right? Like we have to really take that into consideration. And you hate to go through all of this and have a baby or multiple babies that aren't healthy.
Yeah. Because you did mention, for a while we saw from Mariah Carey to J-Lo to Angelina Jolie, all of these celebrities having twins, and you started noticing it wasn't a coincidence. I don't know personally what they went through or how they were able to conceive their children, but it did make you think that IVF leads to twins.
Exactly.
Yeah.
I think it depends on sort of the timing and the technology of when they had those births, because some of those people, their kids are big now. I think, quite frankly, I personally think, this is a personal opinion, some is by request. Especially if we're seeing that now, it's not necessary.
Because Dr. Thompson, I saw 2 heartbeats. Whew. Oh Lord, I would need a minute.
Listen, there's things that are again, it's cute, it's popular, it's fun. For a while too. For example, IVF was considered very exclusive, right? And something that only wealthy women could do as well, too. So, I think that it is a coincidence. It's unlikely that all of these celebs are just having twins when the single embryo transfer rate of 1 good embryo is extremely high, especially in high quality fertility practices, and the multiple birth rate across the country now is probably around 15% from IVF, right? So that's not the day-to-day.
Oh, I did want to ask you about the effects, the side effects of the drugs that you're taking. I know one of my friends did IVF and she gave me a heads up and she said, you're probably going to be very emotional. I was like, me? No. Yeah. And then one day I found myself sobbing about not being able to decide whether I wanted to leave the house or not.
Right.
It was very
No, I know.
So what are the side effects?
So the 2 greatest side effects are bloating.
Oh my gosh.
Because the more eggs you make, the more bloating you're going to feel. That's very normal. And then, yes, you can have sort of a bad PMS or, emotional fluctuations. And a lot of that actually comes from the estrogen crash we see after the egg retrieval. Because when you're taking the injections and you're taking the hormones, your estrogen will naturally get higher. Which estrogen is honestly kind of a feel-good drug or a hormone, I should say. But when you have large fluctuations is when you can kind of see that, your emotions are not what they normally are.
Yeah. So, Jeannette, I wanted to ask you too, when do you realize that you're going to need to take the IVF route?
So it's interesting you ask that because I saw it as surely we won't have to go there, right? It seemed very dramatic. I have PCOS, and actually I'll have you explain briefly what that is to give people some context.
Yeah, so PCOS is polycystic ovarian syndrome. It's a misnomer in that we don't see these large cysts on your ovaries, but what we see, there's a classic appearance of very small resting eggs called antral follicles that are in the ovaries. And they have a typical, what we call string of pearls appearance. So PCOS is basically a hormone imbalance that probably affects 15 to 20% of women. It's very common. And the big issues are you don't ovulate regularly. So you may have a period every other month or every 3 months, which, ladies, is not normal. I know sometimes it makes us happy to not have a period, but it's not normal to not have a period every month.
As you say, it's not cute. Okay.
Right, it's not cute. That's what No. So you really should have a period every month, unless you're on birth control. I'm just going to say that really quickly. If you are on birth control or any sort of, hormonal contraceptive, that's okay to not have a period, and we can obviously get more into that. But so PCOS has 3 diagnostic criteria. You have to have 2 out of 3. One is the classic appearance of your ovaries. The other is irregular menstrual cycles, so menstrual cycles that are greater than 35 days apart, because a normal menstrual cycle is between 21 to 35 days. And then the third thing is hyperandrogenism. And that means either one of 2 things. You can have clinical, which is excess hair growth. So you may have hair growth in a male pattern. You may find even some hair loss sometimes, but generally women will say they feel like they have to wax more than normal, right? Or they see that. And then you could have it also just in your blood. So elevated testosterone or other androgens that we see in your blood. But it makes it more difficult to get pregnant for women who don't ovulate regularly.
Right. Yeah.
That's the biggest issue, is that you're not ovulating regularly. And women with PCOS are at higher risk of things like gestational diabetes, insulin resistance, diabetes in general, difficulty with weight.
Yeah. So I knew for me, it's the missed period. Like they're extremely, it just stops by whenever it wants to. And it's a quick pop in.
Right.
And so I had that issue since I was like 15, 16. I knew there would probably be some challenges. Finally went to the doctor in my early 30s, which was a bit late. And we got the diagnosis. And we thought IUI was going to be enough. We did one cycle or one, I guess, attempt. One cycle. And it was not successful. And I told myself I just didn't want to keep trying and for it to be unsuccessful.
Because that disappointment is rough.
I mean, it was like the anticipation of like, they were like, you got a perfect egg. And they just couldn't give me an explanation. That was the other thing. They couldn't give an explanation as to why it didn't work.
I could probably tell you.
Why? I know, I'm curious.
With IUI, it's very similar to natural conception. So everything still has to happen on its own, in contrast to IVF. So in IUI, you release an egg, right? Or 2 or 3, all right? And then we put the sperm after washing it and getting sort of the best swimmers. So we get the best count and motility, but we can't address other parameters of the sperm as well, too. And then we put that directly into the uterus. Well, it still has to swim to meet the egg. The sperm and the egg still have to meet. They still have to create an embryo. That embryo still has to grow for the first few days in the fallopian tube. And then it has to move from the fallopian tube to the uterus. And then it has to implant. And then it has to grow and divide. The steps that IVF are taking is everything besides that embryo going into the uterus. But it goes in at the stage that it would be at implantation.
See, IVF,
so you skip all of the...
Just like IVF and I are like this. But it was really IVF that you get to control so many. Yeah, you get to control so many.
Why don't you just start with that?
A couple reasons. You can get pregnant with IUI. And in your case, if you're not ovulating regularly, you're not getting a chance to get pregnant.
Yeah, right? They were like, we don't know how much longer we're going to have to wait, I think, for us to try this again.
Right. So, well, we can also bring on a period. We can make you have a cycle. We can make you out. We can do all kinds of things. But IUI is appropriate in young women with PCOS, because you can give it a shot. But I told you guys at the beginning, those pregnancy rates, right? So the IUI will increase those pregnancy rates a little bit, but not that much. So it's reasonable to try. Cost, right? It's obviously going to be cheaper. IUI is also appropriate in women who are using a donor sperm, right? Because they're also, not technically, well, they are infertile in the sense they have a male factor infertility. And we've changed the definition of infertility, I just want to mention, to be any woman who is having difficulty. And actually, I'm sorry, let me take that back. any person, not just man or woman who wants to build their family and cannot.
Yeah.
Okay. And that broad reaching definition allows for coverage for same sex couples. It allows for, men who want to have a child on their own, for them to have the opportunity to have insurance coverage now.
Right.
Because it's not just women that have infertility issues.
Yes. Yeah. Well, there is male factor infertility, which is about 30 to 40% of infertility.
That's a pretty high number.
Very high. And in most of my cases, there's a mild male factor, even if there is a female factor.
Yeah, because it's interesting when you hear a couple talk about infertility, you assume it's a lot of people assume it's the woman.
Right.
Oh
no.
It could be either one.
Yeah. No, definitely both too. And then also, for male same-sex couples or a man who wants to have a child on his own, he will need an egg donor and a gestational carrier. And there are companies out there who are covering that. So it's great that we've expanded this definition.
Yeah.
I want to just tell everybody really quick why it's bad to not have a period. And just circling back to
Please do, because mine is like 3 hours early to the airport every month on time. So,
because I think it's a really important point. If you're not getting a period regularly, then your uterus has a chance of getting abnormal cells. So, what happens is all of those cells that you're making in your uterus are not coming out every month. They're not shedding. So they just build up constantly. And it puts you at risk of what's called endometrial hyperplasia, and also puts you at risk of endometrial cancer. So, I just want to bring that point up. Because I see more and more young women with endometrial hyperplasia and cancer.
So some of the fears that I have, obviously, when it comes to the maternal mortality rate and the higher numbers that Black women see, but there's also a higher rate of infertility among Black women as well. Is there?
So there's been a lot of articles saying that it's like a 2-to-1 and there's a higher rate of infertility in Black women. I think it's hard to judge to make that very blanket statement in the sense that I think Black women are just talking about infertility, now when we never used to as well too. Your race doesn't make you more or less infertile, but I think Black women present later in terms of presenting for treatment. So having Black women become pregnant is more difficult just because I always say, I wish I'd seen my Black patients 5 or 10 years before. I think we are subject to more inappropriate procedures when it comes to treating things like fibroids. I think we're misdiagnosed a lot on endometriosis, because even in medical school, we're taught that endometriosis is a white woman's disease and fibroids are a Black woman's disease. And, neither one is true. Right? Yes, is there a higher prevalence, but that doesn't mean that you can't be affected. And I've found endometriosis is one of the hardest things to treat in infertility, and the prevalence in Black women is a whole lot higher than we thought. So I think that statement is multifactorial.
Okay. I didn't know if Black women were exposed to more environmental factors, for example, that could lead to infertility. But I'm glad you made that clarification.
I think that Black women are exposed to more environmental factors that are making them sicker. In the sense of one, I think there's just a constant microaggression that we live with, right? And that leads to elevated cortisol levels, more stress, which leads to poor outcomes in everything health related.
I was just gonna say, can you walk us through, when a patient comes to see you, this is an important decision for a lot of people. They want to have kids. They've dreamed about it all their lives. And then you hit a roadblock.
Yeah.
So by the time I get into your office, can you walk me through how you deal with the emotional side, but also the medical side of it?
Yeah, no, it's a great question. We talked a little bit about this yesterday too. So I think that finding a connection with your doctor is actually really important because it is a process that's going to involve a lot of trust and a lot of, there's a lot of emotion, but you also have to be able to put the scientific facts together with the emotion that you feel, right? So it's really good to be able to have that conversation. I think I just start off with doing all of the appropriate diagnostic testing and then giving you the facts about that and then all of the options too, because I think you just have to be really well informed about everything that's out there. That's IUI, that's IVF, that's using an egg donor. And we make that decision together, but we have to lay it all out. So I think, doing all of the diagnostic testing, which for us starts with egg count testing, right? And even if you're older and have a good egg count, that doesn't change some of the outcomes too. So there's a lot of different things. We have to look at your anatomy, make sure your fallopian tubes are open. We look at the uterus. We're looking for fibroids, polyps. We look at the male factor. Sometimes we can fix the male factor. Sometimes it doesn't make sense, just depending on where the woman is in the process too. So we look at your genetics. We do genetic carrier screening. Are you guys both sickle cell carriers, for example? Is that something you want to look at in your embryos? Would you go the IVF route for that? So really a lot of decision making, I think, based on facts. But from the emotional part, I think it's just making sure that you have a really good understanding of those medical facts. So that's why it's always good to, you can bring somebody with you if your partner can't come. Have written information, have transparency. Our patients have a portal where they can see everything. So
one of the things that you and I had talked about was like the timing of having found everything out.
Yeah.
I mean, even literally down to the insurance coverage, like before you make a life decision, whether if you're comparing two jobs, it can literally, I mean, this can be the difference between putting out $35,000 or nothing at all. And I guess I found out the hard way.
Yeah.
But yeah, that's one of the things to consider as well.
I mean, I'm just learning from her because honestly, it's one of those things where you don't think about it when you're not in a serious relationship, when you're not at that
you may
point.
see that part of the benefits. You're like, okay, but you kind of breeze past it.
Like I remember she was taking the shots and I'm like, I love that for you. Like I just don't know. I didn't even know what the shots did.
Yeah, too. No, so I think our employers also, and I work with several, companies, and then we'll do educational events and sort of be able to help explain the medical portion of the benefits. And employers are doing a lot better job of explaining that.
Yeah.
And of providing the benefits. So I have women tell me all the time, well, I know it's something that I can't afford. I said, check your benefits.
You never know.
You never know. And I would say probably, and I'm in New Jersey, which is a mandated state for fertility coverage and obviously close to New York and lots of tech companies. I'd say probably 70% of the time they have something that will help them get through.
It's a high number.
Yep. Whether it is, full coverage or they'll pay for certain portions, medications, whatever it may be too. So check your benefits.
I do want to talk about cost, but I also just want to talk about kind of like what you talked about, breaking down the process for your patients. But you have someone who the second time around it fails, the third time around it fails. It's a costly process.
Yes.
It's a very invasive process. How do you deal with that?
Those are the hard ones because I'll tell you, for most women, you'll be pregnant within a couple of cycles. When you get into third and fourth and fifth failures after multiple embryo transfers, then we're kind of talking a different route. We're talking about things like gestational carriers, or we're talking about egg or sperm donation if we have embryo quality issues too. So those are the relationships that, the ones that keep me up at night, quite honestly. Because those are the hard ones.
Absolutely.
I mean, it can be a process for most people in the sense you may need 1 or 2 IVF cycles to create embryos. Most women will be pregnant within 1 to 2 embryo transfers, and it can take time. But I always tell my patients, like, if I'm not worried, you shouldn't be worried. Like, I know, I have a sense and we talk about it. But what you're talking about, that's a whole separate, issue, because that is not the majority of people. Most people will have success. And I think if we're talking about, women who may need egg donation up front and that sort of thing, we have those conversations. We take the time to do it. Like, I'm very lucky in the sense that I'm allowed time with my patients.
That's so tough because you never know. Let's say you've tried 4 times.
Right.
What if the 5th is it? And you hear these stories, celebrities mostly, who talk about it publicly. It was the 8th time.
Yeah.
So I would imagine having that conversation with a patient is so tough.
What I think is interesting is when you're talking about celebrities and what people are sort of publishing, I want to know the facts of some of those stories, in the sense of, did it take you 8 tries to make an embryo, a healthy embryo, because that's a little bit different. How many transfers did you have? So each story is so different. I think it's really, really hard to have these blanket stories where you're not getting details, because also in a patient's mind from the start of a journey 2 years ago and what led up to that, can be very traumatic. But where I like to see all the facts when it comes to those kind of statements.
I want to talk about there's the patient and the doctor relationship, but even the couple themselves. With my husband, before I met my husband, because I knew something was off, I was always worried about, am I going to be able to get pregnant? How do I have this conversation with my future partner that I have this concern, especially if they want to have kids? And I remember when we were dating, and before I had shared it with him, I would see couples with kids.
Right.
And I'm like, I don't know if I can give them that, at least biologically.
Right.
So whether it's the woman, the man, how does the person who's not dealing with the infertility, how do they support their partner?
Yeah, I think, first of all, they should come to the appointments if you can, and be a part of the conversation. And I think, for women going through the injections, it's good for their partner to be there with them to do it. You can give the injections to yourself, right? But I do find that a lot of partners will like to help to do that, just to stay involved. And then I think also just the emotional support and sort of understanding, what their partner is going through, that they can be a little more sensitive during that time. And then if you're having real difficulty, we have couples counselors who are certified in, reproductive counseling. So they can help with coping mechanisms that, I'm sure a lot of people have their therapists, but I think going to a reproductive counselor is very, very helpful for couples. And probably everyone should do that, right? Just to kind of understand what the experience is and how to navigate it well.
I will say one of the things that Robert did that was really helpful was when I was very emotional, he knew, kind of like what you said, he knew that this was part of the whole process or the hormones and all of that. He would give me the shots, especially the first time we did it. So he was really supportive in that way, but literally physically just being there.
Yes.
Getting off of work early is what he would do just to make it to an appointment where he didn't necessarily have to be at. I was going to ask you about extended family and friends. Like I was telling Mona, I was very private about it, not because I didn't feel comfortable telling them, but for me, it's having to break the news that it didn't work over and over again.
Right.
For me, emotionally, I just wasn't able to do that.
Yeah.
But how the heck do you support someone who's going through infertility treatments?
Yeah, I think just to be there. And I think to your point, your audience and who you're talking to and your extended family and friends too. While I'm a huge advocate about being open about the process, I personally don't think you need to tell everybody when you're having an embryo transfer, to your point. I would treat it in the same way as when do you tell someone you're pregnant normally anyway, right? Or you could say you're trying to conceive, whatever that may be. And I think by just, how they can support you if they know is by, being a little sensitive in the questions, you don't have to get specific to ask somebody, oh, did you have your egg retrieval? I know you're going through that. But just, how are you feeling today? Do you want to go out and grab some coffee or tea? Just talk to me, go shopping, do something else. Just know that you're there as an emotional support if someone wants to open up to you. But I think pointed questions, can get a little tricky.
One of the things, by the way, real quick, that I would get, especially being Dominican, is like this whole idea like, girl, you just got to change your diet. You probably have too much sugar.
Right. Always.
Like, I think they look at it like that is so extreme.
Yeah.
I'm sure there are other changes that you could make to your lifestyle and your diet that would help with fertility.
Do you say to that? Because I feel like in my culture, they're like, yeah, like we get pregnant at 40.
Right.
You know what I mean? And I feel like we talked about that too, where it's like, it just seems like.
My grandmother had a kid at 45.
Right.
Yes. You hear those stories.
Well, did you pray?
Yes. Well, my answer to all of that is that God created this wonderful science, truly.
Yeah.
And the Lord is helping those who want to help themselves too. So, at the end of the day, prayer is a part of the process. But it's not the only part, because you're right. We say a lot of it's in God's hands. And those are my answers to that too. So, I think you just have to be gentle with the conversation.
But there's not, and I just want to make the record clear,
Yeah.
there's not certain cultures that are more likely to get pregnant naturally.
No.
Okay. Because that's what they're making it seem like. Like us
Okay.
Somali people, we're good.
There are a few things.
Mhm.
The birth rate in the minority communities in America is we have children at a younger age than our Caucasian counterparts. Okay, that's a fact. And the younger you are when you attempt to conceive, the more successful you're going to be. All right, but it doesn't make your fecundity better. It's just at the time that you're starting to try to conceive. There's that part. The having a baby at 45, generally that's like grandma's sixth kid. Okay, and there is a difference in starting to try and have your first child at 45 rather than your sixth kid, because theoretically you spend all of these years pregnant with multiple kids. You may breastfeed for a year. You're not ovulating during that time. You're not releasing eggs. So maybe you have a higher egg count. That may be a rationale for that. Your body may just be more used to pregnancy. I don't know the full scientific facts on it, but I can just tell you that, conception of your first child in your 40s is very different than, having multiple births.
To that point, really quickly, I want to talk about unexplained infertility after the first child. I'm not sure.
Secondary infertility.
There we go. What is it? And I would imagine someone who's already had the first kid is thinking they're going to try longer because there's no way I
got
be
pregnant.
infertile. Right. So explain that to me.
So what secondary infertility is not getting pregnant the second time you're trying, essentially, or third or fourth time. So primary infertility is if you've never had a child. So secondary is you have one and you're trying for others. Well, it's age related. Okay, because you had your first kid at 33, now you're 36.
And that's a huge difference when it comes to biology. Yeah.
Absolutely. That's the majority of it. I'm not going to knock that there are not other reasons. Is there a change in the male factor, right? Is there a change in lifestyle overall? Did you have difficulty with weight and now you're not ovulating regularly? Because you can have isolated anovulation that's not PCOS. So that means that you can not ovulate regularly and not release an egg regularly, even if you don't have PCOS. The two are not always synonymous. Anytime you're not ovulating regularly, it's more difficult to get pregnant too. Weight, we have an obesity epidemic in this country. So that leads to poor outcomes with fertility and also can lead to not ovulating regularly. Again, not related to PCOS, because our ovaries have receptors that kind of look like insulin receptors. So there's a lot of cross-reactivity with our reproductive hormones and insulin resistance.
So because you went through it, and obviously, Dr. Thompson, you're an expert in this field, how painful is the process? Can we walk me through it? Whether it's egg freezing or IVF, I feel like I will take one route. So walk me through it. Hold my hand.
Hey, you're the patient. So I would say the injections themselves are not particularly painful. They do feel they're like a pinprick. There's one or two of them that may burn a little bit, and you can obviously attest to this, but they're a short needle. So those are the injections to create the eggs. Those are the ones we use in egg freezing as well. They're going to make your ovaries larger. They're going to make the eggs grow. The discomfort is like the bloating and sort of the tightness, and you feel those large ovaries. The egg retrieval should not be painful because you get general anesthesia. And you should get pain medications in recovery, but you're going to feel it, right? You're going to feel discomfort. Really, I think the bloating bothers women more than anything else. The other part that sucks, that is literally a pain in the butt, is the progesterone injections that we use when we're putting an embryo into your uterus. And for those, generally, you're taking them for approximately 6 weeks. It's a single injection in the butt, but it's intramuscular. So that is more painful. I think a lot of them will describe that they feel like they may have a lump in their butt because it's an oil and and it can be, quite uncomfortable. And sometimes you can't sit properly for a little while. But
I would be at the anchor desk.
I know.
right. Yeah. You feel that.
So you're talking about the shots after you get pregnant?
Yes. Yeah.
So
the ones pre the transfer.
Yes.
Yeah.
So that's what it was.
Like the
there was-
progesterone and oil. Yep.
There was a point where I thought I was done.
Right.
Another one.
I thought it was
So
over.
I think I blocked out some of like what needed to be done. So then when I did like the first round of injections, I was like, oh, okay, we're done. And then there was
Right,
that.
the
And I was like,
transfer
are you
process.
kidding me?
Yes.
But I will say, like, it was bearable. It wasn't
Yeah.
anything crazy. What I was doing, though, I was literally like, I would anchor the first 2 hours of the show. During my 7-minute break, I would run to the makeup room, do the shots, and then come back. But then you run out of room because you get sore wherever you put the shots. But it's bearable, and I feel like your pain threshold is pretty high. What I did like, and this is very weird, I like getting my blood drawn.
Me too.
You too?
Yeah, I literally watched them do it. I don't know, something about needles I love. Maybe we should have been doctors. We just
We had a doctor that only blood drawn.
Oh my
Well,
God. Y'all are
really, that's
amazing patients.
Yeah, no, it was great. Like I was just like, oh my gosh. And you have to go like 3 days a week in the beginning. So and they love my veins. So it was like a match made in
nice
heaven.
good vein.
Or is it art? I don't know.
But like you're done. You don't need to come back for more.
But no, so I think it's tolerable. It's totally worth it. And like even looking back now, I'm like, oh yeah, I forgot I had to do that or whatever. You get
You forget until it's time for the next one.
I guess
But it's just like childbirth. I don't think any of it is worse than natural childbirth.
Yeah,
okay, that's
I do have to.
Right. I had my first kid with no epidural.
oh.
What?
Yeah.
Oh my
I mean,
Do you mind if I ask by choice or
By
was it
choice.
okay?
I just wanted to.
My
see what
sister had her 5th and 6th. Yeah.
I was here for the vibes and it all.
It's like, okay. And I just went with it.
Yeah.
And then I did have an epidural for the next two because I got induced, and that
Oh,
Pitocin
okay.
is rough. Yeah.
Okay,
Oh my gosh.
gotcha.
But
So I guess what I'm concerned with too is that I will say I'm self-diagnosed, but like I do deal with symptoms of PMDD. And so my poor husband, because he's gonna, if you guys are telling him that like you start to get emotional and all this, he's like more than every month. But no, I do have concerns
worried
with
about that.
with like more estrogen shots or anything.
Yeah. I think that, like I said, estrogen actually, when it's stable, makes you feel good. You may have some difficulty after the egg retrieval if you are going through that process, but it's temporary. I promise you that. It's not something that's going to last, the next 2 to 3 weeks or even the next month.
Yeah.
So just having your support system around you and kind of understanding, again, what you're going through and nobody holding you to anything, not making any life decisions during that time.
Well,
I tell my patients, I'm like, pick 2 weeks where you really just have nothing going on.
we were like, let's buy a house.
Right. Yeah.
That's why I'm moving 2 years later.
Oh my gosh.
But no, I think you're
Big decision.
I truly am your example of what not to do. But I think you and Jordan, having someone like Jordan, you'll be totally fine. That makes all the difference. Like having a partner who just gets it. I think that makes a big difference. And then your friend group.
Yep.
Too.
Because we have a lot of women doing this without a partner, right?
Yeah.
And it's not easy, but having a good support system is key. I mean, building your village from the baby before the baby's even born is really important.
Yeah.
Let's talk about resources just in general, because one of the things with social media is that you get access to a ton of information, but also misinformation.
Right.
How do you sort through it?
Yeah. I think just start with reputable websites if you really want information about fertility. And those are things like resolve.com. And then also there's the START website, which looks at pregnancy rates, ASRM, which is our patient resource and resource for fertility specialists. Go to the source. I think social media definitely is good for, again, being open and sort of normalizing the fact that infertility is a medical diagnosis. But everybody's journey is different. And I think comparison is often the thief of joy. Right? So you had to be very, very careful, especially if you're in the thick of it. I would start with ASRM, and they give you amazing patient resources and great videos, to lead you through taking the injections. And also they can help you to find support groups in your area as well, too.
Would you, for women of color, would you suggest a a doctor who's of color, or at least how do you consider whether that's important?
I know.
I know,
such a
like
great
my
question.
OBGYN, it was like, absolutely, I need a woman of color.
Yeah, I mean, and my father was an OBGYN, and I, grew up around a ton of doctors, and I have to say, I never crossed my mind, truly, that like growing up, that we had such a shortage of minorities as physicians, right? Because that's what I knew, and so I realized that most people have never met a Black doctor and don't necessarily have the opportunity to go to a doctor, of color, because there may not be somebody in their area. I mean, there are about 60 board-certified reproductive endocrinologists in the country, all right, who are African American.
Wow.
So we're not available to everybody who needs fertility care. So I think if you have somebody in your area and, you're comfortable, with somebody who looks like you, can empathize with you, understands sort of the mistrust in the health system that have been happening and how to address that, then, I think you're lucky and you should seek that out. If you don't have that opportunity, I think just talking to your friends and family and doing your research and, trying to fit with somebody else is fine as well, too, who's an ally. And, I had one of my nurses said to me one time, "Oh, I wish you had a whole team that was Black." And I said, it's not about that. It's about the fact that I want my team to understand the experiences that minorities go through in this country and to be an ally. You don't have to be of color to necessarily do that, since, we don't have enough of us to go around, but everybody else should be learning to be our ally. And that support and that education really starts with our training programs, right? Medical school, nursing school, allied health professionals.
Very well said. I do want to circle back to cost because what are we talking about?
Yeah.
Like, is it thousands, tens of thousands? Like, what
So
ballpark
I
are we
think
in?
ballpark for egg freezing, it really depends. I would say somewhere between $8,000 to $15,000, really just depending on where you go. And I do want to tell you guys that it's very important where you do choose to freeze your eggs and where you do choose to do your IVF, because especially with egg freezing, you want to know that they have made babies from these eggs. All right. So egg freezing only is not a space that you really want to be in the sense of, there are places out there that only do egg freezing, but you want the baby in the future. So you need to know what their thaw success rates are for those eggs. How do they fertilize? How do they grow? What are their protocols? So that's very, very important. For an IVF cycle in the range of $15,000 to $25,000 as well, too. But I mentioned the SART website. You can go on. You can look at pregnancy rates. You can look at, embryo quality.
And this is aside from the drugs themselves that you have to pay for.
It's aside from the drugs.
Yeah.
And then the egg freezing, I forgot the term that you used, but
Thawing out.
to basically, just to hold them basically.
The cryopreservation, the storage.
The preservation
Yes.
process.
So storage fees are probably around.
I pay like $65.
No. So, I mean, no more that I've seen in the tri-state area than maybe $100 a month.
Okay.
Yeah, for storing them.
Yeah.
The actual freezing process is generally part of your package, with IVF, when we actually freeze them.
Okay.
But to keep them stored, somewhere around there.
Okay.
It's not as bad as I thought. I thought it would be.
The storage is not as bad. A lot of women are like, "Oh my God, I thought it was like $5,000."
I did. I don't know where that number came
The storage is not bad at all.
Okay.
It's not bad at all. I think on the high end, close to about $100 a
Because
month.
when you're in your 20s, you're like, we're grand.
Right.
I got student loans.
That is probably more, in line with the process and the medications and the probably on average around $10,000. And then the actual IVF process, because it does involve fertilization, embryo growth and creation, and then generally we do a lot of embryo biopsy where we're checking for the DNA of the embryo.
Yeah.
The technology is expensive. It really is. We can't bring that down. The technology is very, very expensive. The media, the culture, everything that we use is very expensive. So that does make it harder.
So how can folks get a hold of you? Because they're going to be like, I want to slide into her.
Yeah.
So what, I mean, do you have a waiting list? Can they get a hold of you? Are you
Yes,
available for
I,
questions?
I am. I'm available for consults. I see patients as well via telemedicine. I'm at CCRM, New Jersey, so very close to the city, but happy to see anybody nationwide. You can definitely just shoot us a message, and you can follow me on Instagram at Dr. SM Thompson.
Lastly, I did want to ask you, did you think that IVF would be such a political conversation this election cycle?
Yeah. I did not think so this election cycle, not at all. I have a luxury of practicing in the Northeast, right? So, for me, it's not necessarily part of my day-to-day, these questions that do come up about personhood and embryos and embryo storage. But I recognize in the rest of the country, it is a big issue. But I didn't think that Roe versus Wade, would turn to IVF being politicized in the way that it is. And, I think if we start to attack that route, we're really cutting off our nose to spite our face, right? Because you're attacking families and you're attacking family building. And the birth rate in this country is very low. And we need IVF and we need access to care.
To end on a more positive note, I'm curious about what milestones or medical accomplishments do you kind of see on the horizon that would be game changers? Or what would you want to see? Like, what's the one issue that you wish we could tackle in IVF that would be a game changer?
Access. That is the game changer. Allowing everyone to be able to have a family and build a family. And that's really starting with our insurance coverage. There are 14 mandated states out of 50 for fertility coverage. I do think there needs to be somewhat of a nationwide mandate. I think even our government needs to start covering it for their employees. We really need to have access. Our technology, our success rates are amazing now. We can always focus more on the uterus and the uterine factor. I'd love to see more research on that, especially in women of color, because that is often more of our rate limiting step. I feel like we've almost perfected the embryos, but the uterus and everything else, we definitely need to look into more. Genetics keep getting more and more advanced. We have the opportunity to look for single gene disorders in embryos. If you do not want your child to be affected with something that you're a carrier of, we can even do that with the BRCA gene. We can look at embryos for that too. So I think just, having more availability of genetic testing as well is very important.
Any medical frontier that you see us crossing soon? I know you mentioned the eggs once, like biologically, like they age with us.
Right,
yeah.
right. I don't see us being able to take back age. I don't. I mean, there's one thing called mitochondrial transfer that was experimental that, and then now as we talk about stem cell research and that sort of thing, I think it's a long way off. I do. I wish I could say it's next year.
But I think it's also a good reminder of
That's
just
right.
the realities of science right now and where we are.
Biology has not caught up to society.
Yeah, because life
And
expectancy.
That's right. And it's going to take us truly, a lot to get there. But our society is wonderful. We have so many opportunities, and we have a lot of great scientific opportunities as well.
Look at that. So all my aunts weren't being haters. They were right. Let me go. I gotta go. I can't hang out after. I'm sorry. Dr. Stephanie Thompson, thank you so much for joining us, for joining the Quick Chat. And we will see all of you on the next episode of Off the Record.